All right, well, I think we're going to go ahead and get started. First of all, I want to be the first to welcome you to our webinar today, First Case Experiences with Solitaire Mini. I'm Todd Jamalin. I'm the Director of Medical Education here at Medtronic Neurovascular, and we are very glad that you joined us today and given us an hour of your time to hear about a new device and hear about this new device from some key opinion leaders around the country in the United States that have had the opportunity to use this device first. Here's a few housekeeping details. Due to the number of attendees that are on the line today, we're going to keep everyone on mute. We encourage you to ask your questions. These panelists want to answer your questions, so please submit any questions through the Q&A or the chat. We've asked 5 physicians from around the US to share with us their first case experiences with the new Solitaire Mini device. And I expect that we're going to have some lively discussion, and I hope that we even have some debate about these first cases. As our panelists today, we have Dr. Ramesh Grandi, who's a neurosurgeon from the University of Utah. We have Dr. Justin Singer, neurosurgeon from Grand Rapids, Michigan. I noticed that Dr. Singer is not joined yet. He may be with a patient, as I know today was one of his working lab days. We also have Dr. Krishna Amaluru, who's an interventional neuroradiologist from Goodman Campbell in Carmel, Indiana. We also have Dr. Sunil Sheth, who's an endovascular trained neurologist from Memorial Hermann in Houston, Texas. And we have Dr. Adnan Siddiqui, who's a neurosurgeon from Buffalo. Also joining us today is Scott Schumann. Scott Schumann is one of the education consultants here at Medtronic Neurovascular. Scott comes to us with over 10 years of leadership in many acute ischemic stroke initiatives. Scott's with us today to give us a background on this new device before we jump in and begin to review the cases that these 5 physicians have used the Solitaire device in over the past month. So Scott, I'm going to turn things over to you for some background and historical context.
Thanks, Todd. Welcome, everybody. Appreciate it. It's great to be back with everyone. I know we did a training last month on our national launch call. We've done some district trainings, and boy, we've seen a lot of cases over the past month. So this is great to get back together and get some expertise and some tips and tricks from some of our key physician thought leaders regarding Solitaire. So just a quick rundown of what we're going to go through today. I'll be doing just a quick background on the Solitaire X device, talk a little bit about the clinical need, some of the design and specs that we went through last month, talk a little bit about the catheter compatibility, and we will talk through some of these cases with the physicians and get their thoughts on that as well. And then last but not least, we want to leave plenty of time for each of the physicians to go through their cases and then interact with each other as a panel to discuss these cases. So just a quick recap of what the device is indicated for. It's down to a 1.5 to 3 millimeter artery. The indication is for the neurovasculature, which is really including the internal carotid M1 and M2 segments, and then also the basilar and vertebral arteries. We do know that there's a expanded 017 microcatheter compatibility now, so it gives the physician flexibility to use either a 17, 21, or 27 catheter. And again, we go down to a 1.5 millimeter artery. So why Solitaire 3 millimeter? Well, it definitely fills a gap in our stent retriever portfolio, but also there's been quite a bit of data recently that has been released regarding clinical evidence for treating distal clots. And so we know now that via some of the STRATIS data that the endovascular therapy is effective and better than medical management for M2 segments, and then also thromboretrieval and distal artery occlusions with higher first pass effect and lower use of adjunct therapy compared to thromboaspiration. So we know there is an unmet clinical need to be able to treat out into these distal arteries and these smaller arteries that are less than 2 millimeters in diameter. So when we look at what is the same regarding our Solitaire X franchise, it's the same great parametric design. We know that's been with us since we launched Solitaire in March of 2012, over 9 years ago. We have the platinum marker visibility, the 200 push length wire. We do have microcatheter compatibility across our franchise of microcatheters, which are Phenom, Rebar, Marksman. And then more importantly, we have compatibility with our aspiration catheter family of React, which is the 68 and 71, and in our Riptide aspiration system. Some of the things that are different or changing or new for this device is, again, we can treat down into a small vessel size of 1.5 millimeters. We do have 17 catheter compatibility. It does have an 0155 push wire diameter. And for the first time, we have this tapered introducer sheath, which is great to be able to introduce this small device into the back of smaller microcatheters. One thing to remember is if you do have to do a second pass, make sure you do have that tapered introducer sheath up and you're backloading the device into the tapered introducer sheath end. And then we have this unique fluoro safe marker design that we changed. It's more of a tiger stripe configuration. So when we look at the specs, particularly on the 3x20, you've got two evenly rowed space of markers that are every 10 millimeters apart. We still have the 3 distal markers for visibility and then the 1 proximal marker as well. And this is a great depiction of what that tapered introducer sheath looks like right here. There's a small little taper that will help you advance that into the back of the microcatheter. So when we talk about radial outward force, this is some benchtop testing that was conducted in an experimental bench model. And when we look at this, the Solitaire X 6x40, the 440, and the 320, in roughly a 1 millimeter artery, the 6x40 and the 3x20 really have similar radial outward force. And so either device are going to be a fine choice. But what it comes down to is other factors like microcatheter flexibility. What size microcatheter do you want to use to cross that clot? What are you using for proximal aspiration? If you're going to the M2 segment, is it a shorter segment than the M1? And maybe length isn't such a need. So there's a lot of factors in why a physician would choose a 3 millimeter device. And we'll get into some of that, and we'll be interested to hear from our panel on their initial cases. So this is a quick video. This is also on Folio. I'm going to mute this. And what this is testing that was conducted on an experimental bench model. And this is going to show you a Solitaire 3x20 and also a Trevo NXT 3x32. So both devices were deployed in a less than 2 millimeter tapered mock vessel. And both were given the same amount of retrieval force at a constant rate. And what you'll see here is this idea behind it. We really want to minimize the vessel movement or displacement. And as these are pulled, you can see on the left, the Solitaire 3x20 slides very smooth. There's no displacement of the vessel. There's minimal vessel movement as you're retrieving. And then you can see the Trevo on the right does have some vessel displacement. Now, to be fair, this is a 20 millimeter Solitaire X, and this is a longer 3x32 Trevo. But it'll be interesting, again, to hear from our panel on the differences of what maybe they feel with some of their initial cases that maybe they did or didn't feel with using the Trevo prior. This is just showing you another picture of the device and some static images of what it looks like. And the idea is that we're trying to minimize that vessel movement. So without further ado, I want to introduce Dr. Grandi from the University of Utah. He's going to run through his case. And again, we want to encourage all the physicians on the call to be able to interact. And again, if you have any questions, please pose them through chat and we will discuss with the physician panel. Dr. Grandi, the floor is yours.
Hey, everyone. So the first case that I'm going to talk about is this gentleman who presented, 81-year-old, transferred, like many of our patients are transferred from a very disparate landmass pathology here for us. So this patient came in from Montana and was found to have a basilar occlusion in Montana, 81 years old, received IV TPA around midnight last Sunday night, and transferred to us here in Salt Lake City. So right around, I think it was like 6:58 in the morning, we got a call about this guy landing, and repeat, he was not a candidate. Here we obviously have our vascular neurologist seeing them immediately. They were thinking of getting an MR for this gentleman, and then just got that repeat vessel imaging, which showed on the CTA a P2-3 segment occlusion or P2-3 junction occlusion on the right. In fact, the vascular neurology attending called me and said, "I'm just going to park him in the ICU. There's nothing you guys can do for this guy." And I just said, "Listen, man, there's a recent publication in Stroke that showed significant safety and efficacy of clot removal for P2 lesions." And I said, in an 81-year-old, if this guy has a huge infarct, I'm pretty sure his family is going to withdraw care. So the vascular neurology attending said, "Sure, then let's do it." I didn't realize you could do this. So this is my my first angio run. We did do radial access on this guy. I'm not promoting that. I'm just saying that this was fairly straightforward with a right-sided dominant vertebral artery and a diminutive left vertebral artery with tortuosity at the origin. That, to me, that was a pretty slam dunk case to just do it radially because it's just easier in an 81-year-old. So we got up the right vertebral artery, base catheters in the right vertebral artery, and you can see this occlusion on the right side in the right P2-3. I don't know what the right picture is depicting, but there it is.
Looks like we may have lost Dr. Grandi just for a minute. Oh.
Hey guys, can you hear me?
Yep, you're back. We got you. So I just went to your image with the device deployed. Can you see that okay?
Yeah. So
perfect.
Typically, when I do thrombectomy, I like I like using the largest microcatheter that is within reason. So we generally gravitate to Phenom 027, creates obviously a smaller lip or shelf between that microcatheter and the aspiration catheter that we use. I mean, obviously people can argue maybe to use a smaller microcatheter to get out more distally and distal occlusion cases, but regardless, that's my preferred method of getting to the clot. Again, I like being prepared for manual aspiration alone. But I do have a preference to use a stent retriever method of combine local aspiration and stent retriever. So I went out using the Phenom 027-160. Got past the occlusion very easily with our microwire and microcatheter, and then went ahead and deployed our Solitaire 3x20 stent retriever. And I think the couple of things that made me think of why to use this is, number one, again, maybe, yeah, I could have probably used a 4mm by 40mm Solitaire stent retriever, but in my thoughts are, I really don't know how big and how forgiving the distal vascular tree distal to the occlusion is going to be for me. So I thought that the best idea would be to use the smaller profile device. Number two, again, why not aspiration alone? I think you'll be able to see in this slide to the right that I really feel like, apart from many of the arguments made using larger registries, it's just harder to use catheters to get out there distally. And you actually see that this was a Cat 5 that was used, struggled actually to get all the way to the clot interface. So I'm not sure with just aspiration alone whether we could have gotten there without that anchoring provided by the stent retriever. So this isn't mind-blowing. All of the wonderful people on this panel know how to do this and do this regularly, but we did it with stent retriever assisted manual aspiration thrombectomy. And we have our final run, which you'll see in a second, which shows Tiki 3 revascularization. And you see Justin Singer. Maybe that was what the previous picture was supposed to show, but regardless, there was excellent Tiki 3 revascularization. I think this picture might have been accidentally zoomed in a bit
little
too much,
cropped.
but
Yep, you can see the filling up top. Yeah. Dr. Grandi, a quick question for you. With delivering a 027, is that predominantly, like you mentioned, is that to make sure and help you get a larger bore aspiration catheter up? I know you talked about the ledge effect, but it's obviously going to help you deliver some proximal aspiration as well, correct?
yeah, it's all about the ledge effect for me, for why to use the 027. I think maybe my my intra-residency training in Pittsburgh, in which we did a lot of manual aspiration thrombectomy, may just still kind of stay with me, but I believe in using really as big of a rail as possible, and I think that's what the 027 provides. But you know, again, for the sake of playing devil's advocate, you know, the ability to go out into a smaller vessel with an 017 catheter does have clear benefit and has its utility.
Excellent, thank you. Todd, did Dr. Singer join? I didn't see his name pop up on
Yeah,
he may still be.
Yeah, he
Okay.
is not. So why don't we skip past that and we'll come back to it if he's able to join us.
Perfect. All right. We'll pass it over to Dr. Amaluro.
Hi, can you guys all hear me?
Yes.
Yes, sir. Perfect.
So yeah, thanks for having me here. I'm just gonna jump right in with our own experience, and we've had a couple of cases in the last several weeks that we've had really nice success. So here's our first case. This was a 69-year-old female who came in with 3 hours of expressive aphasia and right-sided weakness with a stroke scale of 10. She did receive IV TPA. And here on a lateral view of the angiogram, you can see she has a codominant occlusion of a M2 segment artery with non-opacification of the precentral and prefrontal branches. We are actually involved in a trial that's looking at aspiration alone for certain candidates. So we actually attempted aspiration on this patient 3 times using a Sophia catheter. Unfortunately, we were unsuccessful 3 times, and the trial mandates that after 3 attempts of aspiration, we're allowed to use whatever technique we want. So on the 4th attempt, we were able to get up there with a Solitaire 3x20, and we parked our aspiration catheter immediately proximal to that tight turn that you see there. And just like Dr. Grandi had mentioned, you know, we also prefer to use a larger bore 027 Phenom or Marksman catheter. And I think the other benefit of that is sometimes with these combination techniques, we'll unsheath half of the stent retriever and then use that larger bore microcatheter as an anchor to get that aspiration catheter as close as possible. In this case, in particularly, I was scared that with all the manipulation from the aspiration alone, we would have spasmed the vessel. But you can see on our recanalization view here, very little spasm from the Solitaire 3x20, and we were able to get a great result. I think the next slide is a 24-hour MRI that shows a little bit of cortical infarct, but otherwise a great result. The next case is a 83.
Dr. Amaluro,
yeah.
Can I ask you a question? So
Sure.
back to our first case that you went through. What do you think the difference was between the clot not coming out with the aspiration and using the Solitaire?
I don't have those images up there, but we weren't able to make that turn as distally as we could. There was a really tight turn of that segment coming off, so we were just barely able to get the aspiration catheter meshed into the proximal aspect of the thrombus. You know, with aspiration alone, you really try to get a good purchase with the 5 French or 6 French or whatever have you aspiration catheter. So we just weren't able to make the turn. I will say that when we deployed the Solitaire 3 millimeter, again, as with any anchoring technique, I think we were able to make the turn a little bit more aggressively with our intermediate aspiration catheter. And the fact that, you know, as the other panels will know, you know, a lot of times with these combination techniques, when aspiration alone doesn't work, you know, frequently we will be successful on the subsequent pass.
Great, thank you for the clarity.
So here's our next case. This is an 83-year-old with a left M2 occlusion. This is a slightly oblique view where you can see that, you know, very small M2 segment coming off there. The diameter of that vessel is, you know, probably on the order of 1.2, 1.3 millimeters. So we were able to cross that pretty successfully with, again, this is using an 027 microcatheter, and we performed 2 passes here with a 5 French intermediate Sophia and deployed a 3x20. You can see that there is a little bit of spasm in that distal segment, but you know, with these small vessels, we really are kind of almost reluctant to use stent retrievers when the takeoff of the M2 from the M1 makes a tight turn, just because you're putting a lot of force and a lot of retractive force when you're pulling the stent retriever. But luckily, we've really had no instances of hemorrhage or vessel dissection or any problems of that nature in our, you know, granted limited experience with this 3x20. And you could also see on that previous case, it was a very, very tight turn with the stent retriever that we had to make. So you know, at least in these cases, we've had nice success even when the Solitaire is deployed on a relatively acute angulation. This is our third case. This was a 63-year-old male who came in with left face and arm weakness. He actually had a tandem occlusion here. You can see on the image on the left, an occlusion of the cervical internal carotid artery. A lot of times in the past, we would cross this with a steel-tipped wire or an 014 wire and perform balloon angioplasty. We've had really nice success using what we call a dilator daughter technique, where we cross the occlusion with the 035 glide wire and then take the inner dilator of the prepackaged inner dilator of the guide catheter and use that tapered dilator to cross the occlusion. So once we got up there, next slide, please. You can see that he had a tandem occlusion of that superior division M2 segment, which we were able to cross again with an 027 microcatheter and deployed a 3x20. And you can see here that, again, there is kind of a little bit of an angulation here with where that M2 comes off of the M1, but very easy to deploy the stent retriever, and really no resistance on our thrombectomy pass. There is a little bit of spasm there you can see on the more distal vessel, but this was a 1-pass technique which we were able to recanalize, and I think I have the follow-up internal carotid artery run. So a lot of disease here. This patient actually went for an endarterectomy later that week. And then this is our final case. This was a 75-year-old female who came in with acute onset of left-sided weakness. Here we have a proximal M1 occlusion, which we were able to cross. Our first pass, we used a 6x20, I believe, and we were able to recanalize quite readily. through a Sophia 6 wrench and a larger Solitaire. But here you can see there is a persistent M2 occlusion. So we recrossed on our second pass using the same microcatheter and wire setup, and we're able to deploy a 3x20 in superior division. This is one of the few cases where we remember to take a screenshot of the Solitaire deployed. But you can see here that the Solitaire is deployed, and we're able to, again, use that anchoring technique to get our aspiration cathode a little higher up. And here's our post-interventional angiogram, which shows a nice result. So those are some of the cases that we've had, again, limited experience here, but so far we've had really nice instances of M2 occlusions responding well. And really the thrombectomy passes across those tight angulations is, at least what I feel, is a lot smoother than other 4x20s or 6x20s or even perhaps the baby Trevo.
Yeah, I think very, very interesting case, and we often get asked, where, because we still have the 6x20 as a size, and we certainly, when we launched Solitaire 9 years ago, all we had was a 4x20, and I totally agree with you. I think it's some of those do have a niche use, but the length of the vessel and the angulation or the takeoff of the from M1 to M2 has a lot to do with that. And sometimes, even though we know we have the largest diameter and longest length, but the 6x40 and is the predominant stent retriever used, it's great to see the use of the 620 and use it well. Do you use that in any other instances, or the 420? Because we do get that question a lot of, where would you use those sizes along with the 320?
I think depending on any preoperative CTA imaging and the size of those vessels, I think everyone will have their own protocol in terms of what size stent retriever they go to. But in general, with carotid terminus occlusions, M1 occlusions, we typically do start with, or I do typically start with a 6 millimeter Solitaire device. And I guess every case is individualized after that. With M2 occlusions, we would typically try to use a 4x20 and really try our hardest to almost recapture the stent retriever with our intermediate aspiration catheter, just so we're not pulling that stent retriever across those acute angulations. And we've had a nice success, but a lot of times you're just not able to recapture the entire stent retriever with the intermediate catheter. And in those situations, it is admittedly nice to have a smaller profile device where you can't recapture the entire stent retriever. And there may be a little bit more comfort in pulling the entirety of the stent retriever uncovered across that bifurcation.
Excellent, thank you.
I may ask a kind of a clarifying question. What criteria do you use in deciding if you're going to do aspiration first or use a stent retriever first? One of the things I heard you talk about was, some of the tortuosity and the angularity. Is that the first factor that you go to when determining, am I just going to use aspiration, or is this a better stent retriever case? What criteria are you using, Dr. Amalira?
I think it honestly depends on a lot of the clinical scenario. If a patient has gotten TPA or is on other anticoagulants or antiplatelet, I think most people may agree with me, and they might be a little more reluctant to use a stent retriever, especially in an acute angulated vessel. Patient's age, patient's underlying comorbidity obviously plays a key factors into those equations. And I think sometimes, just crossing the thrombus with the micro wire, sometimes you can actually feel how hard the thrombus is. And sometimes when we cross these thrombi, you just know that, oh my God, there's no way aspiration is going to work for this. And sometimes patients with chronic atrial fibrillation or sometimes a heavily calcified plaque on a non-contrast CT, that you're going to need some combination therapy. But I guess it's really a case-by-case scenario. If sometimes on a CT, if it's not as hyperdense of a vessel, you might be more convinced that it's an RBC-rich thrombus rather than a fibrin-rich thrombus, and you might have more success using aspiration alone. So I think it kind of takes into account multiple variables. But in general, I think prior to recently, less is more, and we've really kind of tried our hardest to use aspiration alone. But I think with the safety profile that we've experienced so far with the 3 millimeter Solitaire, I feel a little bit more comfortable, again, crossing these bifurcations with the stent retriever alone.
Good, thank
That's
you.
great to hear. Dr. Sheff, you're up next.
All right, great. Yeah, thanks for the opportunity to be here. Okay, so I'll present this case. He was a young patient in his 60s, and he presented with the left MCA syndrome. Fairly significant, it's high teens and high stroke scale. And he had several problems, which we'll go through in his angiogram. But as you can see on the CT scan, I showed this because he already had a decent bit of infarcted territory. And so, that I think plays into your thought process, like my predecessors were mentioning, when we think about device choices and approach towards the treatment. So, in approaching these patients, one of the things you want to think about is there tissue to salvage? And in his case, his deficits, were beyond what was already infarcted on the CT scan. So we wanted to go ahead and treat him, knowing that there is some risk in doing the procedure. So he had several problems. As you can see on the angiogram on the right, he had a dissection in the carotid. There's an occlusion there, and we could also tell there was a tandem intracranial occlusion of the MCA. This carotid occlusion was a dissection. I won't go through the details of that because we're focusing on the intracranial work, but similar to Dr. Amaluru, we also use this kind of daughter technique where we open up the vessel. Thankfully, it worked with our devices. So just going up first with a microwire, then microcatheter, and then in this case, our aspiration catheter that we found the true lumen and kind of opened up the carotid and was able to then focus on the intracranial work that way. So he had an occlusion, is that M2 occlusion. You can see on the lateral projection. I similar to Dr. Grandi have loved using 027 catheters, and my choice really is Marksman. I was trained on it, and it's just a wonderful microcatheter that I think is very trackable, and obviously doesn't limit you in terms of your choices of stent retriever. So that has been and still remains kind of my go-to. So this system we used, it was a balloon guide catheter, an aspiration catheter 71, Zoom 71, and then Marksman. Marksman goes past the occlusion, and we deployed our Solitaire 3 millimeters. In this case, again, we were thinking about trying to do this thrombectomy in as gentle a way as possible. There's a lot of literature out there on doing passes in the distal MCA, M2 mobile segments in the sylvian fissure, and the increased likelihood of some bleeding, or at least contract extravasation with more manipulation or with more passes. So we want to do something that would be effective with the fewest number of passes, but also be the most gentle. And this was really, again, our first experience using the 3 millimeter device. In fairness, I before I had a 3 millimeter device, I probably would have been totally fine using the 4 millimeter device, or honestly, probably even the 6 millimeter device. Again, because of the parametric design and the radial force. But here, the 3 millimeter, I think, did a nice job. There wasn't too much spasm in the vessel afterwards, despite the guy being young, and reperfusion was good with that after that first pass. Again, the aspiration catheter size, it's not going to go out that distally, but I think there's been some nice data, particularly at a UMass, showing that thrombus gets lost at a few places, one of them being going around the siphon. So I think if you have an aspiration catheter, you can park it in an M1, a nice horizontal M1, and then drag the device in through that it minimizes some of the places where the thrombus can get dislodged. So this was a case, nice first experience, but look forward to discussion that's particularly around, sizing relative to the other Solitaires.
How did the patient end up doing? I know they had a little bit of infarct before he started.
Yeah, he did okay. He definitely improved. Like he had some deficits that remained, particularly language areas, but his motor symptoms improved.
Fantastic. How one follow-up question on this too, with you using the 27 catheter, what you mentioned that you use the Zoom catheter. Does that track pretty well over that, or do you have to use any other techniques to get the large bore catheter up there? What's been your experience?
You know, Zoom is relatively new to our shelves, but it's been a nice device for me. I know we're not focusing on that in this talk, but you know, with the 027 catheter, I think many of these 071 catheters have less of a shelf, like was mentioned before, and so the trackability is nice. I'd like to go up with a system that's fairly versatile across as many patients as possible. So with a single system, you know, you have the option to have a nice large bore aspiration, plus the capacity to put in any kind of stent retriever you want. So young, old, you know, distal, proximal, you still have a lot of flexibility in what your offerings are. Because sometimes what will happen is you have an M1 that then becomes an M2, and if you already can use the same system to treat it, then you're in good shape rather than swapping everything out for something else. Also saves a little bit of money.
And then what are your thoughts on? Do you usually try to cork the clot right with the stent retriever, or do you pull back in, or do you aspirate and leave a little bit of distance between the stent retriever and then pull the stent retriever back in? I know there's a lot of different methods that people use, and does one have any benefit over another, or is every case different?
Yeah, that's a great question, and I think, you know, technique is something that we're all learning from and refining, and I think we're getting better at. This is a case where I didn't really expect my 071 catheter to get all the way up to the clot. So my ideal situation is if I am able to take out the microcatheter and then cork it. That's what I like to do. So have the stent retriever and the aspiration catheter, no microcatheter in the way. Then maximize the aspiration and the stent retriever function. But there are situations where that doesn't work, this being one of them. So in this situation, I kept the microcatheter in, and the purpose of the aspiration catheter was really just to have a place where the whole device can get pulled in without having to take it through the siphon, you know, and drag it all the way back to the guide catheter, and give it more length and opportunity to kind of get dislodged. The nice thing here was we were able to get our guide catheter past the dissection so we could save our spot. So if we need to do multiple passes. But if we weren't able to do that, then I would have probably, you know, just pulled it through the Zoom.
And Dr. Sheth,
thank you.
A question came in through chat, and
Yep.
Just to confirm with you, I think we've heard from everybody that's spoken already. It seems like there's a lot of consistency here around people preferring an 027 catheter. You said you liked Marksman best. What is it about Marksman versus, you know, maybe a Phenom 27? That is it the support? Is it where the support is? What is it about that's kind of kept you with that Marksman?
Yeah, so I've used Phenom 27 quite a bit, you know, for pipeline cases. I think it's a fabulous catheter for pipeline because it has that tip. I think is just more reinforced and better for pipeline delivery and kind of manipulation. I think Marksman, you know, over just an 014 wire will track pretty much wherever I want it to go. And Phenom 27 might take a little more work in that sense. So Marksman has just kind of been my go-to, and he and I have a nice relationship that's, you know, just been lasting many years. So that's the main reason for it. Fully understanding, like Dr. Rainey was mentioning, that an 017 catheter has multiple advantages too. So if you can use a lower profile, particularly when you're crossing a smaller clot in a smaller vessel, that may decrease the chance of distal embolization and so on and so forth. So you know, I think it's something that we'll continue to try, but you know, in my experience so far, that the Marksman was the device that I used.
Okay, good, thank you.
All right, Dr. Siddiqui, up last, but certainly not least. All right.
Yeah, well,
thank you for joining us, sir.
Thank you very much. So before you play that, let me just sort of say a couple of things. There's nothing cool about my case. I don't think it actually works very well, but I got some nice pictures of the device, so that's good. And it's a video compared to stills. But I would just sort of say I'm impressed with how much you three kind of do it pretty similarly. I'm a little bit of a contrarian in the sense that I always stent tandem occlusions first. I have no qualms about aspirin, Brilinta, the moment, it shows up on Viz and I see that athero plaque there, or I see a significant plaque on the contralateral side. In fact, I did 3 this weekend. Unfortunately, every single one of them was a tandem where I use a balloon guide in essentially all my cases, and then, just go ahead, class D, stent, aspirate. And then there was a question asked earlier, I think, Todd, you asked that as, okay, when do you do what? Well, there are 2 scenarios in clinical practice. And I'm happy that we have a lot of clinical trials going on, like all have mentioned, which force your hand one way or the other based on the protocol. So that's the number one driver in terms of what we do is, okay, what trial is this and what do they want us to do? So that is the first thing. But if there is no particular trial that is like for tandem lesions, you can't really do any trials. It's fairly straightforward. If I can get to the face of the clot without crossing it with my large bore aspiration, I will do aspiration first. If I have to cross the clot to get my aspiration up there, then I'll use a stent retriever. And I think I use the same thing as I think Sunil and Krishna and Ramesh also mentioned is, just with the stent retriever with the aspiration catheter, I rarely leave the microcatheter in there. And historically, I've been concerned with the larger stent retrievers, particularly in the superior division. Those are the ones where I've always been concerned. And we have written about the rate of subarachnoid hemorrhage from traction on those tiny little perforators in the Silvian, because the vessels are just more mobile. And so the other contrarian thing is I want to use the smallest microcatheter I can. So I typically use Phenom 21, and I used to use the Velocity 25 prior to that, prior to 21 being available. And I'm looking forward to doing with 17 catheters. The problem with the 17 catheters right now is they're not the extra long versions right now. They're all 150, and you start running out of length because if you match it, like especially if you're using a 320, you probably use a 4 French or 5 French aspiration catheter, and then those really you start running out of length with the 2E in there. So it'd be nice to have a longer 17 that will work. I don't know if the 320 will go through a duo, and that'll be an interesting. Scott or Todd, do you know if it'll go through a duo, the 167 duo?
I do believe it does based on that internal diameter, but don't quote me on that. I believe it does.
I haven't tried that yet. But there's a lot of enthusiasm over in Europe over this Tiger 13 concept that it's a smaller stent retriever for really distal lesions. I think some of the cases look like that, except I don't like the larger microcatheter, principally because I feel that sometimes it shoves the clot even more distally, and it might be paranoid about it, but that's sort of my mindset that I'd rather use a smaller one. So just a few key differences from others, but let's go ahead and let's play this case, and we'll see what I did here. So this is a 50-year-old who presented with sudden left-sided weakness and facial droop, pretty sizable right-sided infarction. Looks like he's heading towards a rapid progressive core, and NIH is 18. And so can I scroll this, or you probably can't. So go ahead, keep scrolling forward.
Yeah, I'll just kind of take you through it as you're going through.
Yeah. So go ahead.
You just guide me.
Forward. Yep, keep going forward. So you can let it play now. So there is classic M1 occlusion. And so I'm bringing my aspiration catheter up there, but it's really stuck at the with Zoom. So now this is the first one I've done. There's my Zoom aspiration. You can see I didn't cross the clot, and I brought the aspiration catheter up. I have a balloon guide, that's the walrus and the cervical, and then it's being pulled out. So we go from proximal M1 into hopefully something a lot better. So there's still a frontal occlusion that's there. And so superior trunk is still occluded. So we then try to identify exactly where that is and get better ideas. And so now I'm going in with a microcatheter and wire. And I believe it was a Phenom 21 that I used. And there again, I bring my aspiration catheter essentially up till the takeoff that you can see. I'm keeping it up there, do a little micro run to confirm that I'm still intravascular. And then the 321 is being deployed. Fairly straightforward, deployed, and then try to advance the aspiration catheter up again to sort of track it. The balloon is deflated right now, but before I pull, I'll inflate the balloon. And there you can see the Solitaire, which is deployed, and just use aspiration to pull in. And I think this angle thing that people talk about, you can see that the balloon guide is rising up because it gives you an idea as to how much tension there is. And this thing is really lodged in there. And so I'm just pulling it back into my balloon guide, and then we do a run, and it's still occluded. This was a fairly significant core that was there, so I elected to abandon after 2 additional passes. You can stop there. So nothing fancy, nothing as pretty as the others, but I think we can, that's the end of the case. My feeling overall is that I think having smaller catheters and smaller stent retrievers is a good example of being able to chase these things distally. So Neil mentioned that he's shocked that I use general anesthesia. Sunil is right. We typically didn't prior to COVID. I think with COVID, we started intubating everybody. But now we have gone back to our fuzzy mobile pictures with a lot of motion artifact there, Sunil, you'd be happy to note. So next time I show you a video, there's going to be a lot of artifact. Because the entire team is now vaccinated, and so we're not concerned. And so now we are back to intubating people who either are non-cooperative or have a compromised airway. So overall, my points would be that I like to use a smaller catheter. I like to use a 17 to get up distally. I like the idea of smaller stent retriever, particularly for more distal locations. I like to match the vessel with the aspiration catheter, and that's one of the challenges, is to finding the right one. So I'm very much a believer in toolkit, and so my cases end up being quite expensive, where I'll swap things out based on what I started off with and change strategy in the interim based on what I'm dealing with. But it can be a crapshoot. No matter which way you go about it, sometimes things don't work very well. I had a COVID case last night where we did 3 passes with stent retriever, 3 with aspiration. It was an M1 ICO occlusion, and then ended up putting in a stent with integralin, and it still did not open. It's just, and 35-year-old. So just absolutely disgusting, where you think you've got this figured out. It's a cookie cutter, do it again and again, and then you get a nice wake-up call when you lose a 35-year-old's entire left hemisphere. So,
Dr. Siddiqui, what are these Buffalo Bills fans eating up there? Holy cow! 3 tandem occlusions over the weekend, and then that case. Wow. Hey, one quick thing on that. You mentioned the microcatheter, the dual. I believe that 167 does taper down to an 013. So that's not it wouldn't be a true 17 catheter from proximal to distal. So that may be problematic to put put our device through. But you know, we're going to learn a lot more about microcatheter selection and that flexibility. Like you mentioned, you know, until we get more 160 length or longer length 17 catheters, we'll learn more. But with that tapering, that may be problematic.
Yeah, that's
We
why
do
I
have some
asked you,
questions.
because
Yeah, go ahead.
that's exactly right, because you know the Duo 167 has a taper compared to the Duo 150, so you can't really put your standard coils through the 167. So that's why I was asking if you can deliver it through.
So how about questions from our from the group? Any questions for our four panelists today?
I have a question for Dr. Siddiqui, because he just showed that towards the end of his case, he showed that microcatheter run. Dr. Siddiq, are you frequently doing microcatheter runs once you cross the thrombus? And I ask that only in the light of today's discussion with most of these M2 occlusions. I think it is important to do microcatheter runs in these tiny vessels. And a lot of times we will do a microcatheter run, and after doing a run like that, you see the diameter of the vessel. Sometimes that makes me really scared sometimes to deploy a stent retriever like a 4, or I mean, I don't think we would ever use a 6, but doing a microcatheter run like that, seeing a very small vessel and still chasing a thrombus like that, previously it did cause me to pause and say, oh boy, do I really want to put a 4 millimeter stent retriever in a vessel that small?
You're absolutely right. So most of the time, you know, it's not a big deal. Most of the time, you know, you can deploy, it's quite stereotypical, you went around, you feel comfortable. However, I've been burned a couple of times. And that's because when you're crossing the clot, especially if you have an atherosclerotic plaque, you don't realize you dissected and now you're extraluminal. And now you deployed a stent retriever and pulled the clot out of the thing that was holding the vessel closed. So, you know, I've had more than a handful of situations where we went up and did a micro injection and noted extrav. And guess what? I just pulled my microcatheter out and left that vessel occluded, and nothing happened. The patient had a small infarct. These are distal locations. It's perfectly fine. So you're absolutely right. Now, my partner, Ken Snyder, he does this other thing where if he sees really rapid venous filling, you know, just AV shunting, he feels that it's futile and he doesn't do it. I mean, there's, I don't know whether it's dogma or not, but from my standpoint, I'm looking for that inadvertent iatrogenic dissection with vessel perforation or accidental catheterization of distal lenticular striate, thinking you're in the superior trunk and you're in some perforator. So I think doing a little injection really is very useful. So Krishna, I always do it 100% of the time.
I'll just chime in too. I mean, I think that's a great point. Microcatheter injections have gotten a bad rap, I think. You know, in literature, there's a lot of stuff out there about how they cause hemorrhage, this kind of thing. But I also like to do them. I didn't show pictures of it, but with that being said, I also cross lesions much less frequently now because we can aspirate many of these out. But when I do cross it, I do like to confirm that I'm intraluminal, and it doesn't have to be a 1 cc run. You know, I'll just hook up a 10 cc syringe and just a little bit of puff. I think like was shown here was just on the roadmap, not even a phalangiogram. You're just looking to see where we are and getting a gross sense of the vessel size. So I think there is a lot of value to that. And I'll sometimes even just aspirate out the contrast too, so you're not overpressuring the system. So, but I agree with the points. Great question.
I wonder how many, just a little bit of a digression here. I wonder how many of your cases, your partner's cases, Dr. Siddiqui, of when he sees the early, I guess you could call it a fistulous venous opacification. I wonder how many of those are instances of just being wedged, because we actually see similar situations where we're in MMA embolization cases, where we see early venous opacification and we say, oh my God, is there a fistula there? I don't know. Sometimes it might just be because your microcatheter is wedged in a vessel. And I think with more of these M2 cases, with more potentially more people doing, you know, stent retrievers using smaller and smaller devices, and thus more microcatheter runs, maybe we'll see more of these quote unquote early venous opacifications, fistulas cases when perhaps you're just wedged in these smaller distal vessels. I think we're pushing the envelope more and more.
Yeah, I mean, and you know, even if that's not the case, let's assume it's core and sparked. You know, we have Endolo and Tesla going on right now, where you know there may still be value to revascularization by reducing some kind of secondary injury, and then I expect neuroprotective agents. I mean, there's a real hope for those kinds of cases where you could revascularize and perfuse them with things. So I don't do it. I was giving that as a case example of information that he gleans from that run, that he sort of, you know, he really believes that. I just am looking for, hey, did I do am I where I'm not supposed to be, or did I do something I did not know about? And that's good enough. But I agree with you. I'm not sure what that early venous filling, if it universally means core. In fact, I believe that there's no imaging modality that reliably tells you what's core at that acute presentation. It's only in hindsight when you realize, oh, that was futile.
Great dialogue. Any other questions from the audience or comments from the
So
panelists?
yeah, let me, I wanted to ask the guys, so in terms of aspiration, how do you decide the diameter of your aspiration catheter? Do you tailor that, or do you always go up with the same system?
I guess I could try to start answering that. Outside of the trial that we're enrolled in the SOFAST trial, which mandates that we have to use the 6 French aspiration catheter. Outside of that, we do tailor. If we are going with aspiration first, we like to use the 6 French Sophia Plus potentially, or you know, the Medtronic React with carotid terminus and M1 occlusions. Especially in tandem occlusions, it's kind of easier to cross the proximal lesion. And then with more M2, more distal, we'll go with a smaller 5 French Sophia. So we do tailor outside of trial patients. And also, I should say, Basler, the posterior circulation, will always try to aspirate first with probably a larger bore aspiration catheter.
I tailored them. So typically for proximal revascularizations, M1 ICAT, we'll use, I was using React 68, but that's only because we got Walrus fairly late last year. And now with the Walrus, I'm able to use React 71. Phil Towski, my partner, was always using as big as he could for proximal. But for distal M2 and whatnot, or even distal, I see a distal M1, when I see on the contralateral side, the patient really tapering down with some degree of a genuflection right by the sylvian fissure, I will go down to a Cat 5, which is 054, I believe, just to make things safer. And again, I think everyone here has made some really interesting and thought-provoking points in terms of the deflection of the MCA and whether that tortuosity, and I appreciate Dr. Siddiqui talking about it, that, you know, there is an increased rate of subarachnoid hemorrhage in their large experience with this. So we always have to be worried for that. You know, I can only imagine anytime this happens, even after a Tiki 3 revascularization with our vascular neurology team, it leads to, 3 more days in ICU easily. I'm sure all of you guys have that experience, that they're repeating scans all the time to make sure that this doesn't get worse. So
I guess I'm a little bit different. I don't honestly tailor it that much. I tend to try and use the biggest aspiration catheter that I can, which is usually a 7.1 catheter. I actually was a fan of the Jet 7 before, and now I'm getting used to the Zoom 71 and React as well. But it's not infrequently when we can get it to the M2s, and I just like the idea of having the largest aspiration catheter at my fingertips. And plus, the other flip side to it is I haven't been super impressed with the performance of some of the smaller ones, especially compared to 68. The OD is about the same. You're not really getting much by going to 68, and the smaller ones, not the 5 French ones. I haven't seen great results. Now, some of the smaller imperative care offerings, we're going to hopefully give it a shot once we get those going. But maybe those will be better, because I do like the idea of trying to aspirate in some of these distal vessels to make it a little bit less traumatic. But I haven't been super impressed with some of the other offerings in the smaller catheters. But let me also just kind of throw this back a little bit, which is, as we're talking about this and tailoring choice to vessels and stuff, maybe you guys can chime in on your approach. Everyone's talking about MEVOs and distal LVOs, and so what your approach is in terms of how you identify the patients that you want to treat or not. So is it someone coming in with a fresh MEVO, let's say, do these considerations about vessel tortuosity and location, how much do those play into your risk calculation, deciding what to do or whether or not to do it?
So I think I'll jump in there. So most of these are, you identify them during a case and say, oh, you got something you either caused or you didn't know was there behind your bigger thing in the proximal vessel. But in terms of primarily going after something distant, I'm still a little bit reluctant. I'm partial towards a younger patient with a more functional, higher NIH. So I would not go for a P2-3 unless there was significant thalamic burden of disease, or this is a young person with hemianopsia. If it's a older person, I would let it be with hemianopsia. It's sort of a judgmental sort of call, but it really varies based on the area at risk and the patient's functional status and life expectancy, et cetera. So it's a little bit all over the place right now.
Great dialogue.
Yeah. One other quick question, and that is pertinent to the 320, which I think would be good to get people's opinions is, so there are 3 different ways of pulling a stent retriever back. One is all the way back into a balloon guide or guide. The other is corking it with a microcatheter into the aspiration and pulling the two together. The third is corking it into the aspiration catheter without the microcatheter and pulling it back. And the fourth is pulling it back into the large bore aspiration catheter at its, wherever the aspiration catheter might be, typically M1. So what do you do and when and why? I think that would be good from a standpoint of a small stent retriever. All 3. Krishna, if you want to start, yeah, go ahead.
I think in general, probably the latter 2 techniques is what myself and all my partners try to do. I think all of us try to remove the microcatheter just because it's a fairly straightforward technique. And so we do try to either cork and advance the aspiration catheter to the face of the thrombus. And I would maybe even add a 4B to that technique is holding the stent retriever stable and trying to advance the intermediate catheter over the stent retriever rather than pulling the stent retriever in, and which is kind of a modification of that fourth technique. So I think we tried to do either of those two, and depending on how much resistance we get on the pin and push, we either tried to cork it and put the aspiration catheter at least halfway through the thrombus, or cover the stent retriever with the aspiration catheter.
Very similar to Krishna. Try to take the microcatheter out as much as I can. When we can't get it up there, then we'll pull it through.
Agreed.
So you're typically doing 4A or 4B, basically. You're not corking and pulling the two together unless you just can't, and it's really stuck in there. Then you'll pull the two together. Is that what both of you are saying?
At least for me, no. I like to cork and then pull them both out together.
Okay, cork and okay.
Yeah.
All right.
I guess one question I would have for the panelists is also, again, in these posterior circulation cases, we pretty much generally all try aspiration first, just because, we don't want to potentially perforate these thalamic perforators or these smaller vessels. My question is, will the presence of this 3 mm Solitaire make you reconsider or be a little bit more comfortable using a combination technique, or does it not change do you think it won't change your approach to posterior circulation cases at all?
So, posterior circulation, in my mind, it can be very tricky depending on where the occlusion is. So if it's proximal basilar, I'm concerned about ICAD, and I'll always go with aspiration first. And if I see a lumen, I'll just plasty. I'm nervous about pulling a stent retriever and then having this vicious cycle of re-occlusion. Distal basilar, I'll try aspiration first. And again, same rule that if I have to cross with my microcatheter, I'm opening up a stent retriever. Yeah. And that's almost 40%, 50% of the time that I just, or if aspiration doesn't work the first time, then I'll switch.
Yeah, I also like to aspirate primarily, but I'll tell you, a lot of my partners, particularly when the clot is a distal basilar going into the PCAs, one of the PCAs, they will like to put a stent retriever out there to get more clot engagement. So I think this will be a nice offering for that situation.
So Dr. Siddiqui, when you say when you don't have to cross the thrombus with the microcatheter or microwire, what are you tracking your aspiration catheter over then?
Typically just a oven 4-wire, although I'm excited to try some of these larger offerings from the
018 wire, yeah.
018, or now apparently there's a 22 or 23 or 24 wire so the larger Aristotle. So I haven't gotten my hands on the 18. It's okay. I don't think it makes a huge difference between the 14 and the 18. But typically I just like good old Synchro 2 or Aristotle 14 over Velocity or Phenom 21 now, more and more. And usually with the, with Zoom or Sophia, previously with Jet 7, that was enough. In fact, that brings me up. I'm nervous about trying snake in the anterior circulation. Posterior circulation, I've tried it, but just pushing it up. Do you guys routinely use just snaking in the anterior circulation as well?
I almost always have a microcatheter on the clot face.
Me too.
Me too.
Yeah, same.
All right.
Excellent
Great.
discussion. Thank you
Yeah,
all.
this has been fantastic. There were so many pearls that I think came out from hearing the dialogue and just hearing about, each of you coming from such well-known institutions, but having really perfected your craft individually, it's interesting to hear the similarities, but obviously a few subtle differences there also. So I sincerely want to thank each of you, Dr. Grandi, Dr. Amaluri, Dr. Shath, and Dr. Siddiqui, for taking time out of your busy practices to come and share with all of us. You know, we've had quite a few attendees on the phone. I know if they're like me, they've been taking a lot of notes from the things that y'all have shared. So I think each of us appreciate all that. Scott, thank you for taking the time out of your busy day also to share with us. So again, thank you for the time. We hope that you got some great information and some good pearls, and we look forward to inviting you to another Medtronic Neurovascular Academy webinar. Thanks again, everyone.
Thank you.
See you here.
Bye.
Thank you all. Appreciate it.
Bye-bye.
Thank you.